Anyway, a good evening and a warm welcome to you all. Now, first, I would like to acknowledge the traditional owners of the land upon which we meet today, the elders past and present, and those emerging. It's wonderful to be here tonight again and to be holding the fourth and final webinar of our Melanoma Symposium series. We have over 150 people attending from across Australia, and I thank you all for coming along. First up tonight, we'll hear from MPA's CEO and then on to our three expert guest speakers. So first, some housekeeping. At the bottom of your screens, you'll find the Q&A function, which will allow you to ask questions anonymously, and we'll do our best to answer as many as we can in the time frame. We will be recording this webinar, which will be published on our website in a couple of weeks. So now I'd like to introduce Victoria Beadle, Melanoma Patients Australia's CEO, who will give you a brief overview of our services. Thank you, Victoria.
Thanks, Alison, and thank you all so much for making the time to join us for what is the final webinar of our incredibly successful webinar Symposium Series 2020, which has been designed by patients and carers on topics that matter most. We've been very fortunate to be able to bring to our community some of Australia's best and brightest clinicians and researchers working across many different disciplines, all with a special interest in melanoma. Tonight is no different, and speakers tonight will cover a range of very important topics, including the latest melanoma research, targeted therapy and brain metastases, topics that generate much interest amongst our community of melanoma patients and their families. I'd like to thank our speakers tonight, Professor Scolyer, Associate Professor Menzies and Professor Hong, for their time and expertise, and to thank our sponsors, BMS and Melanoma Institute Australia, who have made tonight possible. I'd like to remind everyone here tonight that you do not need to face a diagnosis of melanoma alone, and there is help and support available through MPA, including the National Melanoma Support Line and a range of support groups. All of our face-to-face support groups have gone virtual, making them safe and accessible. Our closed Facebook now has over 1,900 active and engaged patients and carers providing peer-to-peer support to each other in a very unique and supportive environment. We've recently launched a new closed Facebook support group dedicated to carers. We also have a telephone support group designed for people with metastatic melanoma. And a reminder that we have a brand new telehealth melanoma nurse service, which has been generously funded by Melanoma Institute Australia. And this service supports patients in navigating the health system, accessing available services, and making decisions regarding their health. All of our services are free and can be accessed wherever you live in Australia. Please reach out to us to be connected into our support network. Thank you. I really hope you enjoy this evening and the keynote presentations. And I'd like to add one final thanks to our wonderful facilitator this evening, Alison Button-Sloan. Alison is a fierce advocate for melanoma patients and has done a wonderful job in putting together these webinar series and presenting and coordinating. Thank you, Alison. I'll pass it back to you.
Thank you, Victoria. So now we'll move on to our first guest speaker, Professor Richard Scolyer. He is a Senior Staff Specialist in Tissue Pathology and Diagnostic Oncology at the Royal Prince Alfred Hospital in Sydney. He is Co-Medical Director at Melanoma Institute and Clinical Professor at the University of Sydney. Now, he has a very impressive biography, and I'd like to mention some of his work and achievements. Prof. Scolyer provides a clinical consultation service for the diagnosis of difficult pigmented lesions and receives more than 2,000 cases for opinion from Australasia and beyond annually. Richard effectively integrates his clinical practice with a leading award-winning translational melanoma research laboratory. His record includes co-authoring more than 700 publications and book chapters in prestigious journals such as the New England Journal of Medicine, Lancet, Nature, Cell, Nature Genetics, Lancet Oncology, the Journal of Clinical Oncology, the Journal of National Cancer Institute, and Cancer Discovery, all of which have led to 41,000 citations. Richard has presented on more than 370 occasions at conferences throughout the world. In September this year, he was ranked the world's 7th leading melanoma expert in any field or discipline and the world's leading melanoma pathologist. He was an editor of the 4th edition of the World Health Organization Classification of Tumours, the Skin Tumours volume, in which he was the responsible editor for 3 of the 6 sections and authored and co-authored more than 30 chapters. He has also been invited as a contributing author to 6 other volumes of the WHO classification of tumours, including soft tissue and bone, digestive system, thoracic, female genital tract, and paediatric tumours. Richard is also Vice Chair of the Melanoma Expert Panel of the American Joint Committee on Cancer for the 8th edition of the Worldwide Cancer Staging System. He co-leads the Australian Melanoma Genomic Project, which is part of the International Cancer Genomic Consortium, and he was the lead pathologist for the NIH-funded the Cancer Genomic Atlas Melanoma Project, and he chairs the Melanoma Expert Panel for the International Collaboration on Cancer Reporting. He is the lead pathologist and member of the Overseeing Management Committee, Multidisciplinary Working Party, and author for the Australian Melanoma Clinical Practice Guidelines, and co-lead author of the College of American Pathologists Melanoma Reporting Protocol. Together with other MIA colleagues, Richard has been a chief investigator on 3 consecutive 5-year National Health and Medical Research Council program grants and received multiple personal fellowships from the NHMRC and the Cancer Institute New South Wales. He has been an investigator and advisor on multiple phase 1, 2 and 3 clinical trials and is a frequently sought after advisor to industry. A very impressive biography. But I would like to add, Richard, along with our next guest speaker, Associate Professor Alex Menzies and Georgina Long, were recently named on the highly cited researchers list for 2020. This list is the who's who of the worldwide scientific elite and identifies researchers who have demonstrated a significant influence in their chosen field. And in this case, it's melanoma, of course. A very warm welcome, Richard, and I know our audience are looking forward to your presentation.
Wow, thanks, Alison. I don't know where you found all that information out, but it just about take longer than my talk to read all that out. Let me get my talk up. So thank you for those very kind words. And can you see my screen now?
Yes, that's good.
Well, thank you, Alison, and thanks, Victoria. I'm absolutely thrilled to have this opportunity to speak to the audience today. As a pathologist, I don't get the opportunity to interact directly with patients too often, so I'm thrilled to be able to do that tonight. What I wanted to do is to highlight to you some of the ways in which research can drive improvements in patient outcomes, and also to highlight how you as patients can engage and contribute to research, and tell you a bit more about the work that I do. So at Melanoma Institute Australia, our goal is to deliver on 0 deaths from melanoma. And how we organise ourselves to do this is through 3 pillars of activity. So the clinical care of melanoma patients, research and education of healthcare professionals. And tonight I want to highlight how research can be used to supercharge efforts to deliver on this goal. So at MIA, Georgina Long and I have organised our team around these three pillars, and we have three committees of faculty. Faculty are our senior clinicians and clinician researchers and researchers, and they assist us in providing strategic and operational advice related to these three areas. And in fact, we have patients who contribute to our committee, so we're very grateful to Michael Armstrong and Craig Lawn, who sit on the education and research committees respectively and provide us with their important perspective on what we're doing. But patients remain at the centre of everything that we do. So, why is research important? So as doctors, as clinicians, when we're looking after or helping an individual patient, what we advise and suggest how they're managed is very important to them as individuals and can have a big impact on how they ultimately do. And when we perform research, usually for that individual patient, the research we do doesn't benefit them, but there's a possibility, and indeed we hope likelihood, that the research will deliver improvements to many, many other future patients. So it gives us an opportunity to make a difference to many, and this is why research is so important. For us at MIA, our most important research questions come from patients. So this is us at our multidisciplinary team meeting, which we have every Friday morning at 7 o'clock, where we discuss the most challenging melanoma problems. And you might have guessed that this is in the pre-COVID times, before this little pest came and visited us, and we now still meet every Friday morning virtually and discuss our challenging cases. But as I say, it's through this multidisciplinary team meeting that is really the key to our research program, because our program is very much patient focused. And as I say, this is at the centre of what we do. And we're very fortunate that so many patients come and seek clinical care from the world leading experts who work at Melanoma Institute Australia. And they very generously provide us with an opportunity, but I think also a responsibility to try and do more for them and for future melanoma patients by performing research. And at MIA, we invest very heavily on research infrastructure through our biobank, our research database, clinical trials, and laboratory research. And by having all these patients coming together, this is where we get an opportunity to really make a big difference. And I want to highlight to you today some of the research that we've been able to deliver upon because of this opportunity that patients have given to us. So to deliver on our goal of 0 deaths from melanoma, we've developed a research strategy, and that strategy follows the patient journey. So we have 5 themes one theme's around prevention and management of patients who are at very high risk of developing melanoma, another one around early stage melanoma, another one around advanced stage melanoma. And tonight I'm going to present to you some research findings in each of these 3 areas. And we also have themes around survivorship and supportive care, an increasing issue in melanoma, which we're pleased to have, and we're investing in heavily at MIA. And also we have another theme around health economics. So as Alison highlighted, I'm the co-medical director at Melanoma Institute Australia. My paid employment is actually as a New South Wales government employee at Royal Prince Alfred Hospital. This is what I'd like to cover. After making some introductory remarks, I want to address the question about what causes melanoma. Are all melanomas the same? Highlight some new tools that we can use to improve diagnosis and prognosis for patients, and then finish off with a few brief comments about this very exciting area of personalised medicine. So you might think, well, what do I do as a pathologist, and how am I, involved in your care. So for many of you as melanoma patients, you may have presented with a skin lesion that you're concerned about, that you might have consulted your doctor who may have examined it, and depending on their level of concern, may have recommended that you have a biopsy. And if a biopsy is performed, that's sent to the pathology laboratory, and in the laboratory we examine it carefully, cut it up and process it in a way that we can examine down a microscope, and that's when it lands on my desk, and me or my colleagues just look at it and interpret about whether it's what its risk is to you as an individual patient, and we provide a report which assists you and your clinician in deciding on what's the most appropriate next stages of your management. In fact, what we see and report in many instances is a major driver on what would recommend how you'd be managed. And I really want to stress to you, I've said this before, but that there really is a team of highly trained, dedicated people like me who are working behind the scenes, who've got your back, have got your best interests at heart, and really trying to make a difference to make sure you have the best outcomes possible. When it comes to doing research, we're very fortunate in Australia that patients very generously, in many instances, provide us with tissues and other specimens to perform research in the laboratory. And as a pathologist, I play an important role in the bridge between the patient on the one hand and what's happening in the research laboratory. In fact, there's been some very well publicized examples of where pathologists haven't been involved in research and things haven't worked out as well as you would have hoped because of that. So pathology really does play a vital role in ensuring that high standard multidisciplinary research occurs. I now want to address this question about what causes melanoma, and this is obviously important because if we know what causes melanoma, we can prevent it, and obviously prevention is better than cure. We're fortunate, dating back to great Australian work in the 1950s by Lancaster and Nelson were the first people who recognised that most melanomas were caused by the effects of sunlight exposure. We've known this for many years, but we've been able to hone in on what are the various risk factors for melanoma. And at MIA, we've developed some risk prediction tools. So we've developed a tool related to your risk of developing a first primary melanoma, but also other tools around things like if you've had a primary melanoma, what's your risk of developing a second or subsequent melanoma? And if you have a melanoma, what's its risk of spreading elsewhere? And we've made these tools publicly available at a website and at melanoma-risk.org.au. We in fact encourage all Australians to go onto this website and see what their individual risk is. This is me when I type my information on there. So I grew up in Tasmania, where I spent most of my life with, I have pale blonde hair, a few nevi. I've had a previous basal cell carcinoma. So how we've developed this calculator is really around the risks of risk factors for melanoma. So for me, my lifetime risk of developing melanoma is 22%. But it really doesn't matter what your risk is. We all have some risk. So even if your risk is, or someone you know's risk is a lot lower than this, we really encourage them to look up the calculator, but use that to have conversations with healthcare professionals about the importance, no matter what your risk, of practicing sun smart behavior to reduce your risk further, because no matter what that risk is, you still may develop melanoma. Now I want to highlight to you some of the research breakthroughs that have happened over the past decade related to some of our research, and I'm going to delve into molecular pathology, and to get there I'm going to give you a quick crash course on this area, so bear with me for a second. So all of our cells within our body have a genetic code known as DNA, which is illustrated here on the top left-hand side of the screen. And its DNA is formed as chromosomes in the nucleus of cells, and this is what's known as your genetic code. And it's formed by a double helix, this sort of circular movement, and the two strands of the helix are joined together by these bonds. We call these base pairs, and it's when this double helix unravels that we're able to read the genetic code. And when that genetic code is read, our body can then transcribe that code and use it to make proteins. So 3 of these base pairs are used to code for what we call amino acids, which are the building blocks of all proteins, and those proteins get built within cells and form proteins, which basically are used to all functions within the body. They control and influence them. You can get changes in this genetic code, and this can lead in different proteins being formed, or changes in that structure of the protein, and that can cause it to have abnormal functions. In some instances, can actually cause cancer to develop. One of the commonest genes that's involved in having a mutation and having an abnormal form is the BRAF gene, which codes for the BRAF protein. And the commonest mutation that we see is a mutation in position 600, and the normal T or thymidine residue at this site is replaced by an A or adenosine residue, and this codes, instead of the normal valine that's coded for at this location, it codes for a different amino acid, glutamate, and we call this the V600E mutation. And when you have this mutation, it causes what we call constitutively activated BRAF protein. So this schema is a normal cell, or this signaling pathway we call the MAP kinase pathway is present within all cells of the body. This is in fact in a melanoma cell that has a BRAF mutation. The pathway is continuously stimulated, so you don't need an external stimulus to turn this pathway on. The BRAF mutated protein causes the pathway to be continuously activated and causes the melanoma cell to grow and take on other properties that make it form a malignant tumor. Fortunately, these days, Alex Menzies and his very capable colleagues have now developed drugs that can block this abnormal protein and block the proliferative activity that's driven by this abnormal BRAF protein. And as Alex will no doubt to tell us about tonight, usually combined with a MEK inhibitor, which blocks the next protein downstream in this signaling pathway. Now, I'm going to now highlight some of the work that's happened in melanoma is what causes a melanoma. So this is some work from the Australian Melanoma Genome Project that I co-lead with Nick Haywood, Graham Mann, and James Wilmot. So this slide looks very complicated, but I'm going to talk you through it. So each vertical line within this slide represents an individual patient. There's 183 patients. And if we look first of all at the top part of the screen, the patients group into 2 different groups. So you can see a group on the left-hand side, there's a lot more grey than is present on the right-hand side. And what grey stands for is what we call C to T transitions. This is when in the patient's DNA, they've had mutations that have changed from C to T. And the most common cause of this is related to ultraviolet light damage. And these tumours are actually showing an ultraviolet light UV damage signature. If we look down the bottom, nearly all of these patients had cutaneous melanomas. So their melanomas were on the skin surface, which is exposed to the the ultraviolet light. So that's what's causing their melanoma to develop. Whereas those on the right-hand side don't have so much of this signature. And if we look down the bottom, these are actually different types of melanoma. These are melanomas that we call acral or mucosal melanomas. Acral melanomas are melanomas that occur on the palms and soles, and mucosal melanomas are melanomas that occur on wet surfaces of the inner linings of the body, the mouth, genital, anogenital region being the commonest site. So uncommon types of melanoma that are not caused by ultraviolet light. And if we look down the bottom at the part of the slide I've highlighted here, when we look at the mutations that have actually occurred within the DNA, when we look at the context with which they've occurred, so what the base pair is on either side of the mutated gene using this, what we call whole genome sequencing, we can delve even deeper and to see what part of the ultraviolet irradiation has caused the damage to occur. So is it related to direct ultraviolet light damage? Is it related to oxygen-free radicals that have been released as an effect of ultraviolet irradiation, or is it related to pyrimidine dimer formation that's a damaged product related to ultraviolet light damage? So, you know, we can get these clues from looking carefully at the patient's genetic code, their DNA footprint gives us clues about what's causing them. So all these cutaneous melanomas caused by ultraviolet light irradiation, but the non-cutaneous melanomas, there's a whole lot of other genetic footprints that we can see within the tumors. And in fact, some of these footprints have never been described in any tumor ever before, some of which we don't know what causes them, but we're working very hard to try and find that out, because if we can understand what their cause is, then we're in a position to be able to prevent those tumors from happening. I wanted to highlight that James Wilmot just on Tuesday received the New South Wales Premier's Award for most highly cited research paper related to this particular research project. And the beauty about it was that these genetic codes that we've developed from all of the patients, these have been made publicly available, so researchers all around the world are utilising Australian melanoma patients' data to perform and value add to our research, and has really transformed the melanoma field. In fact, I'm very proud of James Wilmot. He joined us as a tumour bank officer in 2006. He subsequently did an award-winning PhD, and now he's first author and a world-renowned researcher, first author in Nature, world-renowned researcher, and heads our translational research lab. So, you know, really a great Australian researcher. One question I've often asked is, what about in children? What causes the melanomas in children? And in fact, when we've looked at young adults and adolescents, we still see the same ultraviolet light DNA damage signature in these young people. And so ultraviolet light is the principal cause of melanoma, even in young adults and adolescent patients. It's different in patients less than 10, but unfortunately melanoma is very uncommon in those patients. Why do they actually get melanoma? It's likely because they've inherited some genes that make them particularly prone to not being able to repair the damage that's been done by the ultraviolet light. Next of all, I want to address this question about, are all melanomas the same? So that's what we've thought in the past, that melanoma could develop by different pathways, but basically all roads lead to Rome. But we now know that that's not true. So I've highlighted the fact already that there's a common subtype of melanoma has the BRAF V600E mutation. Another common subtype of melanoma, which was really discovered here in Australia, was where there's another mutation in this same area, this critical area in the BRAF gene at position 600, where there's a second change in the genetic code where you get a valine, instead of valine, you get a lysine amino acid forming, which we call V600K mutation, which is another common mutation in melanoma. In fact, when the first clinical trials were done for melanoma patients, these patients with this V600K mutation were excluded, and it was because of work that was done here in Australia, including work led by Alex Menzies, that allowed these patients to get on these clinical trials, and we were able to show that they respond really well to BRAF inhibitors as well. So in this work, we were able to show that BRAF mutation is much more common in younger patients compared to older patients. Most of the BRAF mutations in young patients are V600E. And while V600K mutations account for about 20% of BRAF mutations overall, they're more common in older patients. And this is a very important finding of Alex Menzies as part of his PhD that he did under the supervision of Georgina Long and I here at MIA. And Alex, as Alison highlighted, is another one of our now world famous researchers and clinicians who work at the Melanoma Institute. And in fact, I'm very proud of the fact we've been able to identify and support junior researchers who have really taken the baton and taken the field to another level, and Alex is certainly one of those people. In fact, Georgina, when she joined our institute, she was as a Cancer Institute fellow that Rick Kefford and I were the supervisors of, and Georgina was the first to really highlight what was the phenotype of patients who developed V600E mutations. They tend to be younger melanoma patients, typically develop their melanomas on the trunk. And when we look down the microscope, they have a characteristic morphology that we can recognize. And in contrast to the V600K mutant melanomas that Alex highlighted, particularly in older patients, typically occur in the head and neck region. And when we look down the microscope, have a different morphology, and typically patients have very bad sun damage, as is highlighted by this blue solar elastosis that we see here. In fact, there's also differences in how strongly these two different types of BRAF mutation stimulate the MAP kinase pathway that I showed earlier. In fact, how well they respond to BRAF inhibitor therapy. So the V600E mutant tumors stimulate the pathway more strongly than the V600K mutant melanomas. And in fact, the V600E mutant patients respond a bit better compared to the V600K to BRAF inhibitors. But in contrast, V600K mutant tumors have a higher mutation burden because they're related to chronic sun damage, and they tend to respond better to immunotherapy than the V600E mutant tumors. So I think we now know that melanoma is not one disease. There's various melanoma subtypes, and if I use this map of flight paths as an analogy, if we think of London as a melanocyte, the melanocyte can take various flight trajectories and land at different spots, and these are our different melanoma subtypes. And in fact, in our WHO classification of skin tumours, we've recognised that there's 9 distinct pathways or melanoma subtypes so far, but there are in fact other subtypes within those groups, and no doubt we'll identify more as we move forward. But these do have importance now for patients as far as their management and prognosis goes. I now want to highlight some new tools that we have for determining diagnosis and prognosis that has come about through research that patients at MIA have enabled us to do. So to make a diagnosis, usually we examine tissue down the microscope, and once we've made a diagnosis, our second most important task is to really determine how bad or aggressive, how risky that melanoma is. And most of the time we can make the diagnosis quickly, reproducibly and accurately, but sometimes the diagnoses are not straightforward, and there's some types of melanoma that can that look more like a benign mole. So we call these wolves masquerading as sheep, and on the other side of the coin is there's some benign moles that can look like melanomas, and both of these types of tumours are at risk of being either overdiagnosed or underdiagnosed. And in fact, when we've looked at patients who come to our institute for treatment, and about 5% of patients, when we reviewed their pathology, we've changed the diagnosis based on our review, and about 10% of cases, changes in their patients' managements happen based on our review. But fortunately, we've got new tools in our toolbox to assist us in making diagnosis that's come about from research that's been performed. So from the Australian Melanoma Genome Project, we've been identified the most commonly involved genes in melanoma, developed a next generation sequencing panel that we can apply to our tumours that can assist us in making diagnosis. So here I'm highlighting two subtypes of benign moles and melanomas that are can be problematic to make a diagnosis, particularly for people who are not so experienced in diagnosing tumours. And we can, the specifics of what I'm highlighting are not that important, but if you look on the left-hand side, there's a lot more blue than there's present on the right-hand side. The left-hand side are a type of melanoma that's often not diagnosed correctly until after the melanoma's metastasized. And the one on the right-hand side is a benign mole that during pregnancy, sometimes moles can take on characteristics that make them make them resemble melanoma, and that they can be cause concerns. So sometimes they cause problems for diagnosis. Anyway, using this next generation sequencing panel, we can see that there's marked differences between the two groups. So we can use these new tools to improve the accuracy of diagnosis. So once we've established a diagnosis of melanoma, the number one predictor on, for a primary melanoma, its risk of spreading elsewhere, is based on its thickness, so its vertical depth of invasion. And this is because it gets access to lymphatics and blood vessels as it gets deeper, and that's how it spreads beyond the primary site. We've worked very hard to try and identify other markers of prognosis in early stage melanoma, and us and others have published a lot of papers in this regard. And these new prognostic parameters are described regularly, and including new molecular markers for prognosis. And I think in the future, this is where the field is heading, and we will be able to use molecular analysis of primary tumours to predict prognosis more accurately. But we're not there yet, and I think we need additional data before it would be appropriate to recommend routine use of these tools outside of a research setting. So we still use the tool of sentinel node biopsy to assess the risk of a tumour spreading elsewhere. So what is a sentinel node? So a sentinel node is the first draining lymph node from a primary site, a primary melanoma, and it's usually the first site to receive a metastasis. So the idea is that if we identify the site of that sentinel lymph node, and we can do that using nuclear medicine techniques. So nuclear medicine physicians do that, or inject radioactive dye and traces and map where that's headed to and identify where the sentinel nodes are. Surgeons can then inject blue dye into the primary site, trace that blue dye and use a radioactive counter to identify where sentinel nodes are and remove them and send them to me or my colleagues, and we examine them very carefully to look for tumour that's spread to within that sentinel node. If it's present, that obviously indicates a higher risk of the tumour progressing than if there's no tumour within the sentinel node. And so we found that this is a very accurate way to improve prognostic estimates for patients. And in fact, if that node is positive, patients will usually be the issue of their risk, they have a, if they're offered adjuvant therapies, as Alex will tell us about later on tonight, those therapies can reduce the risk of the disease coming back in patients who've got a positive sentinel node. It's been suggested, well, perhaps do we need to keep doing sentinel node biopsy? Can we use all of the features that we can tell out of by looking, examining the primary melanoma carefully? Would that negate the need to do a sentinel node biopsy? So we've assessed this question, and the bottom line is that there's, even if we put together all of the parameters that we report on the primary melanoma pathology, still there's a benefit to the additional information we get from sentinel node biopsy, and that's what's highlighted in this graph here. So the dotted red line quantitates what that benefit is in improving your prognostic estimate by doing sentinel node biopsy. So to assist in identifying the risk of a tumour having spread to the sentinel lymph node, to assist patients in their discussions with their clinicians, we've developed a tool that uses all of this information to predict the risk. So here's us using that tool and putting in various parameters. So this is a melanoma 2.3 millimeters thick with an occasional mitosis that's involving an acral site, so on a palm or sole, that's not associated with surface ulceration or lymphovascular invasion, which are factors that increase the risk of metastasis. This is what the risk is of that particular tumour metastasizing, and that can assist you in your discussions with patients. Lastly, I wanted to highlight the role of exciting area of personalised medicine. In this new era, we're trying to provide to give patients the best treatment at the optimal time to give them the best chance of having favourable outcomes. Traditionally, we thought of the tumour as being the main thing that influences outcomes, but we now know that the microenvironment in which the tumour sits is also very important, as is host immunity. And in fact, environmental factors also influence outcomes of patients. So in this program, what we can do is take biopsies of patients before they're given therapy, analyze, give them the therapy, and some patients will have good outcomes, some patients will have poor outcomes, and we can analyze their tumours and group them into their good and bad outcome, and develop a signature which can be used prospectively to identify patients who are likely to have good outcomes and bad outcomes. And then when we get a new group of patients, test their tumour out to see if they've got the good signature or the bad signature. If they've got the good outcome signature, we can give them standard therapy. But if they have a poor signature, so suggesting they won't respond to standard therapy, we can utilise our personalised immunotherapy program to identify what's going to be the best clinical trial for them to go on, what's likely to be the best drug therapy that'll give them the best chance of getting a favourable outcome. So that's what we're working on very hard at the moment to do. We're very excited about what it's likely to be able to deliver for our patients, particularly those who don't respond to standard therapies or develop resistance to them. And lastly, I wanted to briefly mention some further exciting work that we've been doing, looking at the role of the microbiome in influencing responses to immunotherapy. So, if you have poor, what we call microbial diversity, which was related to not so good diet, you tend not to respond so well to immunotherapy, and indeed you're at higher risk of getting adverse immune related adverse events if you do have therapy, if you have a low microbial diversity within your stool microbial environment. And ultimately, if you have the worst or the least amount of diversity in your microbiome, you're most at risk of not only being a poor responder to immunotherapy, but also developing toxicity. So in fact, these are the patients who we really don't want to give this give immunotherapy to. So this is an exciting additional form of research that's happening at the moment, and we're very hopeful that in the future we will be able to provide dietary manipulation to improve responses to immunotherapy and reduce the risks of toxicity. So that brings me to the end of my presentation. So I've tried to highlight to you the role that pathologists play in your care and performing melanoma research. Regarding what causes melanoma, I've highlighted the fact that ultraviolet radiation causes most cutaneous melanomas, but there are some uncommon subsets for which the cause remains unclear. I've highlighted the fact that melanoma is not just one disease. There's many multiple subtypes of melanoma that need to be managed and treated differently. We've got new tools that can improve the accuracy of diagnosis. Sentinel node biopsy remains an important tool in risk stratification, and we have this exciting new era of personalised medicine, which we hope will improve outcomes further, particularly in patients who are resistant to standard therapy. And lastly, I wanted to thank patients and their families for their generosity in supporting our research program, because in most instances, they themselves aren't the beneficiaries of the research, but it's future generations of patients that are coming through. So thank you very much for your attention, and apologies that I've gone a little over time.
Thanks, Richard. Fantastic presentation. I'm sure there'll be lots of questions coming through at the end. Okay, so let's move on. Now I'd like to introduce our second guest speaker for the evening, Associate Professor Alexander Menzies. Alexander Menzies is a medical oncologist and Associate Professor of Melanoma Medical Oncology at Melanoma Institute Australia, the University of Sydney, and at the Royal North Shore and Mater Hospitals. He has a subspecialty interest in melanoma and breast cancer. He received his PhD in 2015 for research exploring the biology of BRAF mutant melanoma and biomarkers of response and resistance to targeted therapy. And he has an impressive track record for clinical and translational research for this stage in his career. Since 2009, he has been an investigator on over 100 sponsored and investigator-led phase 1, 2, and 3 clinical trials of systemic therapies in melanoma and breast cancer, and in the last 5 years has over 100 publications with more than 6,000 citations in journals such as Nature, Lancet Oncology, Nature Communications, the Journal of Clinical Oncology, the Annals of Oncology, and Clinical Cancer Research. And I would like to add, in 2018, he received the New South Wales Premier's Award for Outstanding Cancer Research Fellow. So Alex supervises PhD students, conducts several investigator-led and sponsored trials in melanoma and breast cancer, and importantly, he manages the important melanoma oncology clinical and biospecimen databases at MIA that underpin clinical and translational research. He serves as a faculty member and research committee member at MIA, is chair of the Department of Cancer Medicine at the Mater Hospital, and is chair of the Melanoma and Skin Group for the Clinical Oncology Society of Australia. Alex has co-established an international clinical research collaboration network between several major Australian, American, and European melanoma centres, providing opportunities for junior research staff, which has led to high impact regional, and His founding and research interests are clinical trials of new systemic therapies for melanoma and breast cancer, biomarkers of response and resistance to systemic therapy, and immunotherapy-related toxicity. A warm welcome, Alex. Thank you.
Thank you very much, Alison. Gosh, again, a very kind introduction, and thank you everyone for joining tonight. I'm a medical oncologist, and my role is in medical therapy of patients. So essentially, I give drugs to patients with melanoma. In the past, our job was pretty depressing. Nowadays, things are looking very bright indeed. And actually, the treatment of melanoma with medical therapy is now probably brighter and better than almost any other cancer. And I think there are great advances we can make into the future. So I'm very blessed to be able to work with fantastic people such as Richard and Angela that are with me tonight, as well as a whole team at MIA. And it's just fantastic that we've recently partnered with MPA and just continuing that, patient-doctor journey. We're a team, we all work together and we all want to win together. Tonight, I'm going to be talking about two things. One, targeted therapy, which Richard touched on. And the second thing is about neoadjuvant therapy. So firstly, we're going to talk about targeted therapy. And look, there are basically three types of medicine therapy for cancer. The first treatment is chemotherapy. This is sort of getting a bit outdated nowadays and certainly isn't something that has ever really been very beneficial in melanoma. Essentially, these are poisons that try and kill cells that are growing and dividing, and cancer cells generally grow faster than other cells in the body. So chemotherapy has been an option for various cancers. In melanoma, not so much. The second thing, which is what many of you will have heard about, some of you may know about even through personal experience, is immunotherapy. This is where we're essentially trying to harness your own body's immune system to attack cancer. And there's already been a presentation on that in this series, so I will only very briefly touch on that tonight. The main other area that's been particularly impressive for melanoma is the development of targeted therapy. So targeted therapy tries to exploit certain features of cancer cells that are different to the other cells in the body and specifically try and block that to stop that process happening. And this has been a big breakthrough in melanoma. As Richard explained to you before, there's a growth pathway that occurs in all cells in the body, but is overactive in melanoma. So what happens in normal cells in the body is a hormone, this little red triangle, can bind to a little, what's called a receptor on the surface of the cell. And then there's a cascade of signals that very orderly and regulated signal down through various proteins down to the center of the cell to coordinate cell growth and survival. This pathway is overactive in the vast majority of melanomas, and it's due to mutations or changes in some of the genes in BRAF here and NRAS, which is a type of RAS. And we'll talk about that a little bit later. When we look at melanoma, Richard showed you quite a complicated slide. I'm going to break this down to something a bit more simple, more what we use and look in the clinic. And this was a study from one of our medical oncology fellows several years ago, looking at patients that presented to clinic in Australia with advanced melanoma and the makeup of their melanoma. And it showed that a large proportion of patients, so nearly 40%, had this mutation in this gene called BRAF. And this has been where the biggest breakthrough in targeted therapy has happened for melanoma so far. As Richard showed you, the BRAF gene is here, and normally at position 600, there's this base called T. It switches to A and you get this V600E mutation. This was a huge breakthrough in the development of the understanding of melanoma, and quite quickly drugs were developed to try and block this mutation. The drugs that we have at the moment are only appropriate for people that have BRAF mutant melanoma. And as Richard explained, about 40% of people have it. There are certain clinical associations, such as young age generally for the classic V600 mutation, the primary site and chronic sun damage. And as Richard explained briefly, there are some clinical phenotypes of patients that typically fit with a V600E BRAF mutation or a V600K or other rarer mutations. So younger patients, less freckles, a higher nevus count, tan easily, intermittent sun exposure. These often fit with the BRAF V600E mutation. Older patients, often men with chronic sun damage and a melanoma that began in the head and neck region, often have a BRAF V600K mutation. So what happens when you have either of those mutations? This BRAF protein is turned on all the time and it fires off all the time. It doesn't need signaling from above to turn it on, and it ignores any attempts to try and slow it down. So the tumors, the cells are growing fast and they keep growing, and that's what happens in melanoma. We can block this protein with BRAF inhibitors. These are tablets, and these were the first targeted therapies developed for melanoma. So these try and block the abnormal BRAF protein just in the melanoma cells. The abnormal protein is only in the tumor cells, and these drugs block that protein there. When you block it, it turns down the pathway. There's less growth of the cells, and often those cells die. So this is a nice slide trying to show you what happens in patients with metastatic melanoma where it's spread around the body when you start these BRAF inhibitors, these BRAF inhibitor tablets. This patient's symptoms get better very, very quickly. Even within hours, patients can notice that they feel significantly better. When we first developed these drugs, and we were part of the first in-human trials of these drugs when I was back at a registrar at MIA, we noticed that some patients that were very unwell, needing lots of painkillers, for example, within 6 hours, they felt fantastic and were sort of wanting to leap out of bed and not needing to take any pain relief. So the symptoms get better very quickly. A patient's performance status, this is an overall assessment of how they feel. You know, are they out and about all day? Are they need to spend, you know, half the day resting, sleeping? These got better very quickly as well. When we did a PET scan, this is a scan that looks at the sugar uptake of the cancer cells, the activity of the cells. Those scans got better very, very quickly. And then the tumor cells also shrank when we looked at a CT scan. By about week 8, we could see that the tumors had shrunk quite quickly. These responses were far faster than we see with chemotherapy in other cancers, and really were quite striking. In advanced melanoma, when we gave the tablets to people, nearly everyone responded. So this is what we call a waterfall plot, and every bar is a patient. This is a change in the measurement of their cancers on their tumors based on a CT scan from beginning to the first scan. And you can see that most of the people have a shrinkage, that's a falling of the size of their tumors, including a group down the right here that have a complete disappearance of all the melanoma on scans. There's a very small proportion of people that don't respond to these tablets that have BRAF mutant melanoma. So nearly everyone responds up front to these tablets, which is great, particularly if people are really unwell when they first get diagnosed. One of the problems though, like a lot of treatments with oncology, is that these treatments stop to work after a while. So this is what we call a survival curve. You have two groups of patients. These were patients on chemotherapy, which was the old way we treated melanoma. It wasn't good, and we don't really do that anymore. And this was the BRAF inhibitor tablets. And you can see when you start, these are people that had their melanoma treatment wear off and their cancer was growing. And as you go on, more and more people, sadly, are having their melanoma start to grow again. When you gave the tablets, their melanoma was kept under control for longer, but over time, they too had their melanoma start to grow. And it meant that after about 6 months, the tablets didn't work anymore. So whilst we had really good response rate initially, the problem with this was after a while, the tablets started to wear off. The next thing to talk about targeted therapy was, well, it wasn't all plain sailing. It wasn't as if these treatments had no side effects whatsoever. By and large, the side effects with targeted therapy were very mild, and they often involve things like skin rash or skin reactions. When I told you before that the tablets block the mutant or the abnormal protein just in the cancer cells, we worked out that in normal cells that have a normal protein, when we give this tablet, it can actually paradoxically turn on the pathway faster in normal healthy cells. And what happened here is you could get what we call hyperkeratosis, or like calluses on the soles of the feet and the palms of the hands. You could get these less important warty-like growths on the skin. And sometimes we could even see squamous cell carcinomas, which are generally not very risky, but annoying locally aggressive skin cancers that often are just simply removed with surgery. But we did see these things happening, and far more often than we used to see in melanoma patients that have obviously had a lot of sun exposure. We saw a lot of itchy or frustrating rashes that were very self-limiting and not too much of a problem. But one thing we also saw with one of the BRAF tablets in particular is that people got very sensitive to the sun. And you can imagine a patient that's had melanoma already is trying to stay out of the sun. They don't want any more sun exposure. But people, even after, as you can see on the right here, 15 minutes in the sun, people get burnt very quickly. And about 50% of patients on one of the tablets called vemurafenib could get significant sunburn, even through the window of the car, some people even through the window at the office. So this was really annoying, and particularly in places like you're up in Queensland, it was really difficult to give this tablet. Luckily, some of the other BRAF inhibitors didn't have this problem. But the big issue and the problem that we've been trying to study for a long time, and there's around the world, is that resistance emerges. So whilst a lot of people respond up front, as I said, unfortunately, a lot of people then develop resistance. So this is a graphic picture, and I warn you that this is certainly not typical of what happens with normal patients. But you can see a patient on the left here before treatment that had lots of melanoma under the skin, had lost a lot of weight, was very unwell. By about 4 months, he was feeling much, much better, and a lot of the spots had shrank away. But sadly, 8 weeks later, he was back at square one and sadly passed away soon thereafter. And the trouble with this, and we at MIA have been a part of the research here, is there's multiple reasons how the melanoma can become resistant to the targeted therapy. And the other problem, unlike in other cancers like lung cancer, there's often multiple resistance mechanisms occurring at the same time in a patient, and even within the same tumor. So it makes it very difficult to try and work out what's the next treatment to try and override that. Nearly all the mechanisms result in reactivation of that growth pathway that I showed you earlier. So what was another option to try and block this pathway with targeted therapy? And that was to try and block one protein level down in the cascade called MEK. And there are 3 MEK inhibitors that have developed. They also lead to a reduction in cell growth and cause the melanoma cells to die. But the response rate when they were given on their own was lower. Only about 20% of patients responded. And interestingly, the toxicity was quite different. When people got skin toxicity such as acne, folliculitis, they had some hair changes, occasionally could get some diarrhea, and very rarely could have changes at the back of the eye or the heart. These were very rarely a clinical problem. These were seen based on routine scanning and testing of well people just in the clinical trial setting. So we had 2 treatments that both could work, but let's be honest, not as well as we'd like, and they had differing toxicity. And the thought was, well, why don't we try and bring them together? Normally in cancer, if you add 2 treatments together, you get more side effects. But the thought here was you might actually be able to reduce it, because the BRAF tablet in normal healthy cells makes this pathway more active. If we could maybe block this a little bit lower in the normal cells, you might get rid of some of the side effects. But also, if we try and block this pathway harder in the cancer cells, maybe we can kill these tumors off more effectively and for longer. And what we saw exactly that. So there were several clinical trials performed of the combination versus a single tablet alone. And again, you can get a sense here, more patients were responding to therapy. We were getting deeper responses, and it was more durable. So this is the single tablet BRAF inhibitor. This was a combination. More people had their disease under control for longer. But the problem was they still developed resistance. And the average patient would have their melanoma start to grow again after about 12 months. What about longer term outcomes? So what happens long term when you give targeted therapy for metastatic melanoma? Unfortunately, only about 20% of patients have ongoing control of their melanoma by about 5 years. It translates to about 1/3 of patients alive if only they were only to have targeted therapy at 5 years. And in contrast with immunotherapy, we think we see better longer term survival with immunotherapy, maybe up as to half the patients being alive and well, having had immunotherapy at 5 years. So targeted therapy is an option for patients. It certainly is more effective in the short term, but immunotherapy is very much at the forefront of clinicians' minds and patients' minds at the moment in melanoma. When we gave the combination of therapy, as I said, what was interesting, we saw less toxicity. We saw some more fever and fatigue with the combination tablet. And this tablet I'm talking about was the first treatment, dabrafenib and trametinib, but that was very self-limiting. If you took the tablet, had a bit of a flu-like fever syndrome, you could stop the tablet, that would wear off, and often we could get back on the treatment soon after. Importantly, we saw less of that skin toxicity, and we saw less of these new squamous cell cancers developing compared to the single tablet on its own. So overall, people actually felt better on the combination and it worked better. So what are the current options we have for metastatic melanoma with targeted therapy? There are 3: dabrafenib, trametinib, vemurafenib and cobimetinib, or the most recent treatment, encorafenib and binimetinib. There have been no head-to-head trials showing which one is better or not, and we consider these as mainly differing based on side effects. So with the first combination, dabrafenib and trametinib, fever is quite common. With the second combination, you can get rash, joint pains, occasionally inflammation of the liver, and that sun burning photosensitivity problem I mentioned before. The last combination can cause some inflammation of the liver and have some gastrointestinal side effects. Again, all these side effects are readily reversible and manageable. These tablets are all taken twice daily, every day until resistance. We occasionally need to adjust the dose schedules based on side effects. So the main options for melanoma really are immunotherapy and targeted therapy. And just briefly, there are some differences that I'll just highlight. So in terms of targeted therapy, it's only suitable for about the 40% of patients that have a BRAF mutation. Immunotherapy, in principle, is suitable for all patients. Targeted therapy is given via tablet. Immunotherapy is via a drip. The response rate is very high for targeted therapy initially and lower for immunotherapy, only about 50%. The onset's very fast with targeted therapy and slower generally for immunotherapy. But the difference here is the durability does not seem as good with the targeted therapy. With immunotherapy, we can have long-term control, and I actually think we're curing many patients with metastatic melanoma now, which is fantastic. And I think that's the goal, as Richard's highlighted, 0 deaths from melanoma. The side effects are quite different. So reversible side effects with targeted therapy, and rarely people can have some permanent side effects with immunotherapy. So you can see the decision of which treatment you may use for a patient with BRAF mutant melanoma is complex, and we have that discussion with the patient, talking about the pros and cons of all the options. Next, we're going to talk about neoadjuvant, or what we call pre-operative therapy. So you may be well aware there are various stages of melanoma from 1 to 4, and these are based on the thickness of the melanoma and whether it's spread to lymph nodes around the body. Stage 1, 2, 3, and 4. Stage 1 to 3 melanoma is considered early stage melanoma, and 4 is advanced melanoma. The risk of recurrence with early stage melanoma increases as the stage goes up. And this is where we've made some recent big breakthroughs here as well. So we've treated people with advanced melanoma. We also know that we can now give medicine therapy in the patients with early melanoma to reduce their risk of recurrence. Why do we need it? As you can see on the left here, based on the stage of melanoma, 3A is the least risky stage 3 melanoma, often with microscopic deposits of melanoma in those sentinel lymph nodes Richard mentioned, up to patients that have multiple bulky lymph nodes. You can see the risk the survival from melanoma, if we, in an era where we just did surgery and didn't really have very effective treatments, was relatively poor, even as low as only 24% at 10 years if you had bulky lymph nodes involved with melanoma. I would argue even 88% at 10 years is too low, and we needed to do something about that as well. Furthermore, even with people that didn't have melanoma that travel to the lymph nodes, these people are still at risk of melanoma recurring and sadly dying from melanoma. So there's a lot more work to be done in this space. The principle to date with early therapy for melanoma has followed a lot of other cancer treatments, where patients have a melanoma, you cut it out, and then you give drug therapy after. And we've had multiple trials. I'm showing you 2 examples here of both targeted therapy and immunotherapy in the post-operative setting. And you can see the bottom lines here are what we call the placebo curves. This is what we used to do. We just observe people. And the top curves are when you give the drug. And essentially, you're getting more people alive and recurrence-free for longer when you give medicine therapy after surgery. And there's about a 50% reduction in the risk of recurrence. But I'll argue that's not good enough. So taking targeted therapy as an example here, there's a bunch of people, if we treat everyone up front, that were never going to recur anyway. There's a group of people that even if we give the drug therapy, their melanoma comes back. And there's a pretty small, although 20% is still significant, and if you're one of those 20, that's of course important for you, but there's about a 20% chance, only about a 20% benefit by about 4 years of the drugs making the difference. And the problem is we can't identify who these people are. So everyone gets treated, everyone gets a year of drug therapy, which costs the government about $150,000. It requires monthly visits to the clinic and scans every 3 months. Is there another way? Is there another way to try and treat people in a better way, perhaps for a shorter duration, to get better outcomes? And that's what we think is the neoadjuvant approach. So instead of adjuvantly, where we cut out the tumor and then give drug, we give the drug first and then cut the tumor out. And there's a lot we can learn from doing the treatment in this sequence. So what we do is we have a patient, perhaps with stage 3 melanoma with bulky lymph nodes. We give drug for about 6 to 8 weeks, and then they have their surgery. We can do biopsies along the way to get a feel for what's happening, and we do scans as well. And then we can look at some important information that are not normally available if you have surgery up front, particularly what we call the pathological response rate or the pathological complete response rate. That means when they take the tumor out, put it under the microscope, Richard can find no melanoma left anymore. And we wonder whether that may be a really good marker of people that will do well long-term. So again, this is a paper that Richard helped co-lead. The melanomas are cut out. They're cut up very finely and looked at by the melanoma pathologists, looking at the degree of response that they think they can see that the tumors had in response to the therapy. And we can see at the bottom here, this is what we call a complete response rate, where there's no cancer left. It can be as high as nearly 50% with targeted therapy. Immunotherapy, a single drug, or a combination drug, even higher. And any degree of response is getting quite high. So this is where, you know, more than 50% of the cancer we think has been killed off. About 2/3 of people with targeted therapy and nearly 3/4 of patients with combination therapy can have this. What happens if you have a complete response to therapy? You are at much lower risk of your melanoma coming back again. So instead of in the old days sort of saying, oh, toss of a coin, 50-50, we can be far more precise now in telling people their likelihood of melanoma coming back based on whether they've had a complete response or not. The other thing we can do, if you haven't had a complete response to one treatment, we might even think about switching you to an alternative treatment after surgery, because you may have, in a way, identified yourself as a patient needing more therapy. And this is even more impressive when we look at immunotherapy on the right here. People that have a complete response to immunotherapy seldom have their melanoma come back again, at least over the first few years from data we've looked at to date. Interestingly, even if you don't have a complete response with therapy, these people seem to be doing better than if you just give the surgery first and give the drug after. Unfortunately, with targeted therapy, things aren't so clear. Yes, people do better if they have a complete response to therapy, and they sadly do very poorly if they don't. But even if you do have a complete response to therapy, still 1 in 5 patients have their melanoma back by 2 years, and that's not good enough for us. So why would we want to think about neoadjuvant therapy? And I'm going to stress this is very much in the clinical trial only setting at the moment. We hope to have this treatment routinely, readily available for patients outside of trials in the near future. But some of the advantages are you can have shorter treatment, and you could get that tailored prognosis. That means you get personalized, tailored follow-up. And if you don't respond very well to the first treatment, we can switch to an alternative treatment. It's like a second crack to try and beat this. The potential disadvantages, there have been concerns that maybe people might progress on the drug therapy before surgery. We haven't seen this with the targeted therapy. But we have seen it on occasion with immunotherapy. But interestingly, if people do have their melanoma grow in that 6-week period on the drug therapy, often it's spread around the body. And we don't actually think that had we done surgery 6 weeks ago, we would have necessarily prevented that happen, because probably those seeds had been sown around the body before the patient presented to the clinic. The other potential disadvantage is there may be some toxicity, particularly if we're giving the combination immunotherapy. And as you may have heard before, when we give 2 immunotherapy drugs together, you get more side effects. But a lot of new concepts are coming in this space, and there's a group that we are part of all here at MIA called the International Neoadjuvant Melanoma Consortium, a nice long name. And we're trying to pool efforts around the world with our patients in tow, partnering to try and make big breakthroughs here. So we're going to run a clinical trial of preoperative versus postoperative drug therapy. We are running trials where we do less surgery. Instead of cutting all the lymph nodes out, we give the drug, just sample 1, and if that's enough, we don't do any more surgery, which is great in terms of side effects from surgery. We're doing trials with personalized neoadjuvant therapy, a bit like what Richard presented before. And we think this is a better way to develop new drugs. We can develop them faster and cheaper, and we really want to accelerate drug development in melanoma, but also cancer. So that's a bit of a whirlwind tour through targeted therapy and neoadjuvant therapy. I'd like to thank you for joining me tonight, and thank all the teams at MIA and MPA. On the right, here's a poster of the medical oncology group at MIA wearing their Game on Mole t-shirts that no doubt many of you have seen. And I really would like to thank all our patients, families, friends, and carers. We cannot do this work without you. So thank you.
Thanks, Alex. I have lots of questions for you at the end. But anyway, we'll now move on to our last guest speaker, Professor Angela Hong. Now, Professor Hong is a radiation oncologist at Melanoma Institute Australia in Sydney. She's been an active investigator on several radiation therapy trials with the aim to advance the treatment of melanoma. She's a keen advocate in applying new technology in the management for advanced melanoma. Angela is a member of the Australian Melanoma Clinical Practice Guidelines Panel and was the lead author on the chapter called Radiotherapy in the Management of Advanced Melanoma Patients with Brain Metastases. So Professor Hong is going to discuss the diagnosis and management of options for patients with melanoma brain metastases, which I know is a very important topic for many here tonight. A warm welcome, Angela. Thank you.
Thank you, Alison. Thank you for the introduction. So what I'd like to do over the next 20 minutes or so is talk to you about diagnosis, management options for patients with melanoma brain metastases. So I'll go through the incident, how do the brain metastases get there, symptoms, investigation, and different treatment options. So how common is secondary melanoma in the brain? So for someone with a thin primary melanoma with no evidence of lymph glands having the melanoma, it's actually not common at all. However, for someone with stage 4 disease, 25% of them will actually have secondary in the brain at the time of the first diagnosis of the stage 4 disease. And somewhere along the journey, 50% would develop secondary in the brain. We classify or stage melanoma by T and M stage. So M stands for metastasis. So M0 is when there's no evidence of any secondary anywhere in the body. M1A is when there was secondary in the skin, soft tissue, or distant nodal sites. M1B is in the lung. M1C is in other internal organ. But when it comes to brain metastasis, it's actually the highest stage, M1D. So how did they got there? They got there by blood. So you could have a primary skin melanoma on your leg, few cell or even just one cell got into the blood and follow the circulation and end up in the brain. the brain is one circulations. And that's an important concept, because often when you see one metastasis in the brain, there could be smaller one somewhere else in the brain. We just can't see them on scan because they are too small. So we look at the brain by using either a CT scan or MRI scan. So a CT scan is a CAT scan, looks like this, and it's a very good quick scan. So if someone comes through emergency with symptoms, headaches, we can do a scan very quickly, 2 to 3 minutes with contrast, and you can get a quick look at what's happening in the brain. However, MRI scan can give much more details in terms of the size, the number of metastases, and the locations. So this has no radiation, using magnetic field, and it's very good at looking at the brain structure and soft tissue. And this is what MRI scanner look like. Has what we call a tunnel. So it's very small, and there's a coil that go over the head there. You don't actually feel the radiation or the MRI scan, but it's very noisy. Not everyone can have an MRI scan. So for example, if you have a pacemaker or metal implant anywhere near the brain, you can't have an MRI scan. So the panel here on the left show you a CT scan of the patient came in not feeling great with headaches, and a CT scan you can see one deposit here and a second one here. The next day we did an MRI scan to have a better look at what's going on in the brain. So you can see the same 2 lesions. However, you can actually see the smaller one that we could not see on the CT scan. So MRIs can give you a lot more details. So melanoma brain metastasis actually have a range of presentations. Could be something very small that we can only see on MRI scan, and it's not causing the patient any symptoms. Could be a single, just one large metastasis causing lots of local symptoms, or could be multiples in many parts of the brain, front and back, left and right. In terms of symptoms, so patient can have no symptoms, so what we call asymptomatics, and we found a secondary in the brain because we did a scan to fully stage the patient. Or the patient can have very general symptoms to rather sudden onset, and that's usually due to bleeding. And melanoma has a tendency of bleeding into the metastasis. The general symptoms are related to a higher pressure inside the brain, so what we call increased intracranial pressure. And you can see on this MRI scan here, so if there's a large brain metastasis, and in the surrounding area, this dark gray area is what we call swelling. In fact, you can see the brain structure is slightly pushed to this side here. And so patient can experience headaches, nausea, and vomiting. And patient can also have focal symptoms depending on the location of the brain metastasis. So it could be speech problem, feeling a bit weak, or double vision. In terms of general management, we use simple analgesia for headache. Short-term steroid tablet is very good in terms of reducing the swelling and works very quickly. Some patients might need an anti-epileptic to stop or reduce the risk of developing a seizure. And we advise patients do not drive a car whenever there is a new diagnosis of brain metastasis. Now, in terms of management of brain metastasis, is truly a multidisciplinary team input. So there's 3 main ways of treating melanoma brain mets: surgery, radiotherapy, and drug treatment. We often, during our team discussion, we talk about possible clinical trial that might be suitable for the patient. What is the best combination and sequencing? Do we do surgery first before go with drug, or do we use drugs and radiotherapy at the same time? And we also consider the patient preference as well. This shows you how we generally manage melanoma. So if someone have no symptoms, we generally go with drug treatments. If someone presented with a symptom, headaches or weak on one side, then we think of local treatment first. And the local treatment can be surgery or radiotherapy treatment. And often patients will go on to have drug treatment. And for someone who are on treatment and somewhere along the line they become symptomatic, then we can go and think about treatment for that patient. Neurosurgery, so is generally is an open surgery. They use a navigation system to do what we call en-bloc resection, meaning removing the tumor completely rather than just removing bits of it. Generally, we use surgery when there's a need to quickly relieve the symptoms. Sometimes we need the surgery to get a piece of tissue to confirm the diagnosis of secondary melanoma in the brain. So this could be in someone who had a thin primary melanoma many years ago, come in with a new symptoms, and on the scan seeing secondary, and we can't be sure whether the patient had melanoma or not. So that's another reason why we would consider surgery. And sometimes we use surgery after progressions, after drug treatment and radiotherapy. Generally, surgery is used for larger lesions, so more than 1 centimeter in diameter. Typically, it's a few days in hospital, and the risk of surgery depending on the location of the actual brain metastasis. So as an example, this man came in with lots of headaches, not feeling well. You can see the large metastasis, about 2.5 centimeter in size, with lots of swelling on the side here. And he had surgery to remove that, very quick response in terms of the headaches getting better. And this is the MRI scan performed 2 weeks after the surgery. You can see the cavity was clean. There's no sign of any residual melanoma. And you can see the swelling actually came down very nicely. The local failure rate, so the chance of the melanoma coming back at the site of surgery, is about 6% in 1 year and 8% in 2 years. However, patient with a single brain metastasis is at risk of getting another one somewhere else in the brain because of that blood circulation. The risk is about 50% at 1 year without any additional treatment. So it's important that we think about what can we do to reduce the risk of something else turning up elsewhere in the brain after the local treatment. So drug therapy, Alex gone through this. So systemic treatment will treat everything, metastasis in the brain and outside the brain. And the 2 main treatments are immunotherapy and targeted therapy. This is a study led by Professor Georgina Long, co-medical director at MIA, using immunotherapy in asymptomatic brain metastasis patients. So with the 2 drugs, so 2 immunotherapy drugs, the response rate is 56%. 1 drug, so anti-PD-1 alone, the response rate is about 20%. As Alex mentioned, targeted therapy tablet, they work very quickly, but not durable. So often patient can feel a lot better very quickly, but by 6 months, about half of them will start to progress. So it's not a durable treatment option for patient with brain metastasis. Now, what is radiation treatment? So radiation is using electromagnetic waves. It's a form of energy. We define radiotherapy by Gray, which is absorptions of 1 joule of radiation energy per kilogram of matter. So the electromagnetic waves is a range from TV, radio, microwaves, ultraviolet light, and radiation we use is down here. So it's very short wavelength ionizing radiation. The 2 main mechanisms of action, one is directed DNA damage. So directly hitting the DNA destroy the cell ability to reproduce. So healthy cell can repair the DNA damage, but cancer cell cannot. The second mechanism of action is indirect damage. So the radiation interacts with the water in the body and generate free radicals. And these free radicals can then go on to cause the damage in the cancer cells. in terms of radiotherapy machines, you probably all heard about proton, gamma knife, linear accelerator, CyberKnife. So are they all the same? So what I like to explain to patients is they are all very, very good machines. They can all get you from A to B, but most important thing is you need a good driver, someone who can navigate, know the right time to start the engine and take you from A to B. So pretty much all machines are very good in Australia. Stereotactic radiosurgery, or SRS, is probably the most common way we use radiotherapy in looking after the patient with melanoma brain metastasis. This is the face mask we use. So we no longer use a full face mask or use a head frame. It's an open mask, so it's not covered over the eyes or the nose. And the patient lie in the bed, X-ray come out from the machine. The red light is not the radiation. It's actually a scanning camera, three-dimensional, checking the position of the body and make sure it's in the correct position before the radiation beam is turned on. And typically it takes about half an hour, 40 minutes to deliver the radiation treatment. And we use high dose, 1 to 5 fractions for each course of radiotherapy. So this is a patient with a 1 centimeter metastasis and is located in a very deep location. So they was given a single dose of radiotherapy here, and this is the MRI scan after the radiotherapy, and you can see the cavity that's left behind. Now, it doesn't work that quickly, so often can take 2 to 3 months before we see a reduction in size of the metastasis. The control rate is depending on the size of the tumors, ranging from 70 to 85%. This is a lady with a larger metastasis. Even though I said larger brain metastasis, we prefer to have surgery, but sometimes the location is just too deep or too risky that surgeon would not recommend an operation. In fact, this lady already had surgery before, and she had another metastasis, not really suitable for surgery because of the location, and she was given 5 fractions of radiotherapy over 2 weeks and responded very nicely, fairly gradually over a year with a reduction in size of the brain metastasis. We can treat more than 1 brain met at a time. So this is a patient undergoing a course of radiotherapy with multiple brain metastasis or treated in the same setting. The treatment time is still about half an hour each time. And there's actually good data to support using radiotherapy up to about 15 brain metastasis in terms of providing a durable response. Whole brain radiotherapy is another form of radiotherapy to look after patients with brain metastasis. We use it less often now, so this is giving a full dose of radiotherapy to the brain. And we use this when patients have multiple metastases, despite having drug treatment, surgery, or stereotactic radiosurgery. And typically is 5 to 10 treatment over 1 to 2 weeks. And each day is still about 10-20 minutes each day. There have been 2 advances in terms of delivering whole brain radiotherapy. The first is using a drug called Mymentum. This is a tablet that we normally use for patients with Alzheimer's disease. And clinical trial has shown that using this tablet at the same time of whole brain radiotherapy can minimize the impact of radiotherapy on the neurocognitive function. So it's 1 tablet a day for 6 months. The second advance in whole brain radiotherapy is using hippocampal avoidance whole brain radiotherapy. So this is when you give the full brain radiotherapy, you deliberately avoiding the hippocampus, which is 2 very small organs in the middle of the brain. And again, this has been shown in a very good large clinical trial showing that using hippocampal avoiding whole brain radiotherapy can minimize the declines in cognitive functions such as the executive function, memory, and learning at 4 to 6 months after the whole brain radiotherapy. just showing the hippocampus. So it's very two small organ in the middle of the brain there, and they are responsible for short-term visual and verbal memory. So when we give whole brain radiotherapy, we can give a nice even dose and sparing these two structures. So managing patient with melanoma brain metastasis is complex. Cancer Council Australia has a clinical guidelines showing analyzing the evidence, recommending the best treatment approach for patients with melanoma brain metastasis. And one of the main points is multidisciplinary care. And it said multidisciplinary care should be considered in the management of all patients with stage 3 and 4 melanoma. And that is a very important point. And so this is the MDT, multidisciplinary team at the MIA. We meet every Friday morning at 7 o'clock, go for 2 hours. And often we discuss about 15, 20 patients. And it's not just the clinicians, pathologists, Richard here, showing us the pathology. We have radiologists. Often the radiologists will look through 5 or 6 scans over a year, showing up individualization, which one is responding, which one is getting bigger. We have researchers in the team, dermatologists, specialist surgeon, neurosurgeon, lung surgeon, all providing input. And despite COVID time, we still meet every Friday at 7. So on that note, I'll stop here.
Thanks, Angela. Was a very interesting presentation. May I ask everyone to, all our guest speakers to come on, and we can go through some of the questions that people have asked. Where's Richard? Has he disappeared? Ah, there you are. One question that is, which I find quite interesting, is someone has asked about game theory, about resistance, you know, where you stop treatment before resistance begins. Now, I remember hearing this actually with Grant MacArthur and the research scientist. I think she was from the Netherlands. So, but anyway, a patient must have heard it too, and they've asked the question. And I'm wondering who would like to answer that question, or briefly explain what game theory is.
No, I have to pass that to someone else because I don't quite understand.
I'll have a crack, Richard.
Yeah.
So I think this is really talking about the idea that preclinical studies have shown that if you keep cells in the dish under drug therapy long term, in a way you kill all the sensitive cells and the resistant cells learn to emerge and grow up and then take over. And the idea that if you could perhaps give intermittent therapy or give different types of treatment, you can sort of keep the cancer guessing, and you basically keep the resistant cells from having fertile soil to grow and flourish. That's certainly was thought to be possible in melanoma, and there are preclinical studies that looked at that and suggested that if, for example, you gave intermittent targeted therapy, you could basically suppress the cancer, maybe not eradicate it, but you would leave the sensitive cells around and dormant and prevent the resistant cells growing up. Unfortunately, the first clinical trial that was reported this year that tried to do that, to prove intermittent therapy versus continuous therapy, that actually showed that that didn't work. Now, I don't think it's the end of the game there. I think there's more to be done there. I think maybe the dosing and the scheduling could be improved, but definitely there's more we can learn in this space. And in a way, in melanoma, we've hit on 2 big things at the same time with drugs. Targeted therapy, immunotherapy came along at the same time. And to be honest, at the moment, outside of clinical trials, we're giving them without really understanding the best way to give them. And I think there's going to be a lot of research going on, including that we're part of, to try and better give the current treatments we've got as well as find new treatments. So hopefully that answers it.
Yeah, I find it fascinating, and obviously some patient has picked up on it as well. A question that someone asked me earlier, I surveyed the patients, the MPA patients on our closed Facebook group about what they would most like, about what questions they would like asked. And someone wanted to know, if you were given neoadjuvant therapy, which one would be better, targeted or immunotherapy, if you had the BRAF mutation?
Or I'll jump in as well, and Richard and Angela pipe in if you like. So number one, very clearly, just to clarify, we have not done trials testing one versus the other, and giving the targeted therapy, the immunotherapy in the early melanoma space may be very different than when we give it in the metastatic space. So in the metastatic space, we think immunotherapy may be better for that long-term control. In the early space, it's a bit different. We've just pulled together the first 6 big clinical trials done in neoadjuvant therapy. We're about to publish that soon as part of that INMC group that you saw on my slide. It does appear that potentially immunotherapy may be a better option than targeted therapy. But again, it's not true head-to-head data. It's not proven yet, and there's more work to be done there.
Add that Alex is the lead author on that paper, which will be in Nature Medicine shortly. So he's the perfect person to answer that question.
The other question that someone has asked is, they've been on Dabtram, they've been on the BRAF and MEK inhibitors for 6 years. Is there any evidence that she should stay on them, that they should stay on them indefinitely, or could they safely come off? That's 6 years.
Yeah, that's I mean, number one, fantastic result. I think it's fantastic. We do have people that have long-term benefit with targeted therapy. The data that, again, we're much more comfortable in stopping immunotherapy in response than targeted therapy. So most of the trials and most of the development with targeted therapy has been ongoing treatment. We and others around the world have published our experience when people have stopped, either due to patient choice or side effects or whatever. And usually that was after about 2 years, and about 50% of patients remain melanoma free, and 50% of patients had their melanoma reawaken. They could go back on to targeted therapy and it could work, or they could switch to immunotherapy. But it wouldn't be, I don't think it would be standard practice to stop without a reason such as toxicity or other things in this setting. I think without obviously knowing all the details, etc., I can't provide specific advice, but in general, we would recommend ongoing treatment. Acknowledging that may not be. Yeah.
Yeah. So there you'll need more data before you can,
correct,
advise people that they can come off the drugs.
Correct.
Okay. So a question that came up too was, under what circumstances would I be able to regain my driver's license if I had brain mets? I've had I could have had radiotherapy treatment, and I'm now negative. Would one of you sign off a patient to go and get their driver's license back? Because that's a big fear with a lot of people. When they get brain mets, it takes away their independence.
Angela.
Sure. Yeah. No. We advise patients. In fact, anyone with a new diagnosis of brain tumor, whether it's melanoma or primary brain tumor, shouldn't be driving. It's for their own safety and everyone else around them. So after neurosurgery, the rule is 6 months, no driving. Without surgery, in general, if someone have no symptom and have the appropriate treatment and on scan with no evidence of progression, when showing a response, they can go back to driving. Yeah.
Okay. All right. Now, the question is with the BRAF and MEK inhibitors, someone wanted to know, that's 2 inhibitors that you're now using. Are there any more inhibitors that are in the pipeline that you could throw into that combination?
Yeah, so look, there's nothing at the moment in clinical practice. There are many more in development. For BRAF mutant melanoma, we're looking even lower down that cascade. There's a thing called ERK, and there's research there. For other types of melanoma, I mentioned that there's a thing called RAS, which is another gene sitting above BRAF. Recently, that's been a very hard thing to target and develop a drug. But in lung cancer, they've recently had a drug successfully developed there. So I think that's coming. My concern is, though, that the Achilles heel of targeted therapy is resistance. And I think whilst we do want to continue research there and development, a lot of people are now really trying to get on the immunotherapy train and really trying to crank up that even more. But I think we can improve in both ways.
Okay. Now I've got a question for Angela from someone who was on the Facebook page the other night. They have leptomeningeal disease, and she's asking if there's any data suggesting who might develop this. I don't know which one, who would like to pick up that question?
I don't think we know any specific predictor of someone who more likely to develop leptomeningeal disease, meaning there's lining of the brain getting melanoma rather than the actual brain itself having a melanoma deposit. And we are seeing a range of presentations. There could be a small amount of lining showing the metastasis, or could be a full brain down the spine as well. So in short, we can't predict who's going to get leptomeningeal disease. It's not a common presentation at all. Yeah.
No, it's not, no. But we've come across a few on our Facebook group, and sadly, some haven't made it, and others are still, with it. So,
yeah, so in general.
So another question was, yeah. Sorry, Angela?
No, in general, someone with leptomeningeal disease, the prognosis is poor than brain metastasis. But there's still treatment available. We can try.
And with, is there an option, someone asked if they've had the BRAF MEK inhibitors, then they've had immunotherapy and then had progression. Are you able to re-challenge with the targeted therapies after those two?
So there are data that support re-challenging with BRAF MEK. So if you had the target therapy and you go off it for a while and go back on it, you can respond again. Unfortunately, in Australia, the PBS, which is what funds the drugs here, don't permit necessarily going back and forth off tablets. Clinical trials are always a great option in this scenario and upfront, because if you have treatments on clinical trials, that is PBS agnostic. But really talk to your clinician. Generally, we can find a way. Generally, we can find a way for retreatment to happen.
Yeah. And what is the difference? People often say nivolumab, one of the immunotherapies, is better than Keytruda, or the other way around. What are your thoughts on, is that patient doctor choice?
So I guess
does it matter?
Yeah, very briefly, there's no head-to-head data. There is no suggestion that they are any different in terms of benefit or side effects. The only difference in my mind and my colleagues are, one is given every 3 weeks, one's given every 4 weeks. To be honest, that's the only difference. I don't see any difference at all between the two treatments. So it's a decision for the patient to make with the information, but as a clinician, I see no difference.
So I'm going to finish with Richard. We hear that Melanoma Institute Australia often talk about 0 deaths with melanoma, which is a great goal to have. But how realistic is it that there will be a cure, what you could call a cure for melanoma, say in the next 5 to 10 years?
Well, it's a great question, Alison. And to be honest, I think in all likelihood, there are a percentage of patients with advanced melanoma that Alex, Georgina, and Angela are curing already. I guess we as doctors, we're cautious about saying that. So, but in truth, that's what I honestly think, that a significant percentage of people are now being cured who would have died from their disease a decade ago. And it may be up to 50% of patients with advanced melanoma. Perhaps Alex will comment in a moment on that. But to get to 0 deaths, we've still got more work to do. It's likely that it'll come through incremental gains rather than the sort of game changes that we've seen over the last 10 years. But we're heading in the right direction, and yeah, I'm cautiously optimistic that we'll get closer to that figure in a decade.
Yeah. Alex, would you like to add something?
I think
I could see you nodding.
Yeah, I think look, I'd like to think potentially half the patients with advanced melanoma are being cured. That means there's half that the journey is not done. We obviously, with adjuvant therapy now, we're going to try and prevent people getting to stage 4. But clearly there's a lot more work to do. And as Richard said, we need a much more personalized approach, very much along what we're doing here as a research group to improve outcomes further, and learn how to use the drugs with radiotherapy, with surgery, etc. There's so much more we need to learn, and we're researching all of that as much as we can.
Sure. Okay. Well, look, I'm going to bring it to a close here. There've been some great questions, and on behalf of MPA and Professor Richard Scolyer, Professor Angela Hong, and Associate Professor Alex Menzies, I thank you all for coming along tonight. We, as I said, this webinar has been recorded and it will be uploaded in a couple of weeks. If you check on our social media and our website, you'll pick them up. So thank you very much, everybody.
Thanks, Alison. Congratulations.